Hi everyone, I'm Dr. Vyshnavi, and today we are here to discuss on the tricky series where we will be doing all the tricky MCQs for your discussion. So this class is basically going to be a moderate to a high level difficult session. I have shared the 15 MCQs prior on my Telegram channel for you to go through the questions, and now I'll be quickly discussing the solution to all these questions. So basically, this is to keep you on track because the NEET PG has got postponed, and I don't want you all to lose the momentum. So every week, I'll be posting on Saturdays 15 difficult, moderate to difficult questions on my Telegram channel. And subsequently, 1 or 2 days later, I'll be giving you the answer solutions on my YouTube channel. And this is going to be very quick and very fast solutions. We're not going to discuss in detail of any theory topic over here. If there's anything that you want, let me know in the comment section below and we'll get started with the class. So the first question that we have here is a 17-year-old girl who's diagnosed to have velopharyngeal insufficiency after adenoidectomy. The most important muscle that is responsible for maintaining the velopharyngeal competency is functioning poorly. So which nerve supplies the affected muscle is the question. So whenever we say velopharynx or velopharyngeal competency, what we mean to say here is the nasopharynx gets cut off from the oropharynx when we swallow, and this is because of certain muscles. The first one being passivant ridge, which is formed by the palatopharyngeus muscle. Along with that, we have got the levator veli palatini and the other palatal muscles. All of these muscles are supplied by the pharyngeal branch of the vagus nerve, and hence this should be your right answer. So now that we know what is velopharynx, what is the muscle responsible for velopharyngeal competency, we also know that the nerve is supplied by the pharyngeal plexus or pharyngeal branch of the vagus nerve. The point to remember here is this pharyngeal or velopharyngeal incompetency can be a possibility whenever you're doing an adenoid surgery because you are very close to the palatal muscles. And if you accidentally traumatize the levator veli palatini or the tensor veli palatini or the palatopharyngeus, which form the palatal aponeurosis, post-operatively the patient may complain to you of nasal regurgitation. So these keywords are something that you should keep in mind. So with this, let's go to the next question where they're telling to you about a 47-year-old woman who's having right-sided tinnitus and a sense of fullness in the ear since 8 months. Audiometry is telling to you that there's a mild conductive hearing loss. Otoscopic examination is showing to you a red mass appearing in the retrotympanic region, and this becomes pale with pressure changes in the external auditory canal. So this much so far what we have read about tinnitus, conductive hearing loss, vascular lesion, reddish lesion behind the tympanic membrane that is becoming pale on applying pressure in the external auditory canal. All of this points us towards glomus, but we'll also read the question ahead. HRCT of the temporal bone shows to you that there is a small enhancing soft tissue lesion over the cochlear promontory, which means that now you're thinking about glomus tympanicum. There is no erosion of the jugula foramen or internal auditory canal. So this tells you that it is not glomus jugulaire. So now we know that our diagnosis is glomus tympanicum. Now the question is, which of the following best characterizes the histopathological appearance of the lesion? So the question is on histopathology. They are not asking to you about glomus at all. They're asking to you about what is the histopathology of glomus tumor. So the history is telling to you about glomus, and this you can identify by by the history, by Brown sign, which they have given, CT, which is showing to you that there is an enhancing lesion on the promontory. So now that you know the glomus, we are thinking of glomus histopathology. So when we talk of glomus histopathology, we know that there is a pattern that we see, which is called as the Zell balance pattern. So what is that pattern called as? A Zell balance pattern. So what is Zell balance pattern? So Zell balance pattern are basically chief cells which are surrounded by spindle-shaped sustentacular cells, which we have read. Whether it is glomus in the middle or glomus elsewhere, you will have the same histopathological feature where you see nests of uniform chief cells within spindle-shaped sustentacular cells. Now, in the first instance, most of you could have also thought about the first option, which is vascular channels lined by endothelial cells. Yes, this could be a possibility in glomus, where we have studied that there are a lot of vascular blood vessels. It is lacking the media layer, it is only endothelial lined. But there is nothing called as without cellular atypia in glomus. Now, this lesion where you have vascular channels lined without cellular atypia, this is something that we see in a hemangioma, right? So this is something that you would see in hemangioma. Proliferation of capillaries within a myxoid stroma is again seen in various, tumors like neurofibromas, where there is a lot of glycosaminoglycans in the matrix. So if they ask you about pseudo rosettes and neutrophil rich background, this is something that you would see in ependymomas. So now you know the correct answer. The correct answer is nothing but it is nests of uniform chief cells which are surrounded by sustentacular cells which are seen in glomus tumors. So with this, we have solved the second question. Again, the trick here was to identify first the diagnosis, second, not to get confused with option A, and to know that glomus bodies are basically chief cells and they have these spindle-shaped cells surrounding them. So this was the trick in this question. Let's go to the next question, where we have a 6-year-old boy who's having a 2-year history of intermittent foul smelling right ear discharge. So they're telling to you that this patient has a right ear discharge that is intermittent, and there is a recent onset diplopia and difficulty in walking since the past 3 days. On examination, the patient is alert but has ataxia, right-sided SNHL, and a lateral rectus palsy on the right side. There is no mastoid tenderness, and tympanic membrane appears perforated with an active discharge. So this typical scenario is very much specific of Grady-Negos syndrome. What is Grady-Negos syndrome? Whenever there is a petrositis, inflammation of the petrous apex, there will be involvement of the fifth nerve, there will be involvement of the sixth nerve, and there will be persistent ear discharge. So they have given to you that there is a lateral rectus palsy. They have given to you that there is a patient who's having diplopia. They have given to you that there is active discharge coming from the ear. So this is all suggestive to you of petrositis. But can you also notice that there are some additional features given to you, like difficulty in walking and ataxia that is mentioned in your question there? Yes, so it is not just petrositis. There is something more than petrositis in this question. So now let's go ahead and see. A contrast MRI of the brain shows a ring enhancing lesion in the posterior cranial fossa. So if you see that there is a ring enhancing lesion in the posterior cranial fossa, compressing the fourth ventricle with perilesional edema, what would be your diagnosis? So we know that the petrous apex is in very close relation. So we know what is this? This is our petrous apex. It is in very close relation to our brainstem, which is covered with the cerebellum. So whenever there is an inflammation of the petrous apex, will there be Grady-Negos symptoms? Yes, which is given in your question. Yes. From here, can the infection go to the cerebellum to cause a cerebellar abscess? Yes. And can this present to you with ataxia, difficulty in walking? Absolutely. And now when you do a MRI, would you see a ring enhancing lesion which is specific of a brain abscess anywhere in the brain, whether it is temporal or cerebellar? Yes. Now that you know that this is a cerebellar abscess which is going via the petrous root into the inner ear, from the petrous root to the cerebellum, we know the diagnosis is nothing but the cerebellar abscess. Now, why not temporal lobe abscess? Temporal lobe abscess would present to you with hemiplegia, aphasia, and temporal lobe symptoms which are not seen. What symptoms we have is cerebellar symptoms, and the root is via the petrous. It is not via the tegmen. If the tegmen would have been eroded, then it would go to the temporal lobe of the brain. So I'm sure now you got this trick here. You just don't have to answer Grady-Negos because it's more than Grady-Negos. It's not temporal lobe because the root is not tegmen. Lateral sinus thrombosis wouldn't present to you like this at all. It would present to you on an MRI with a delta sign and empty delta sign. So with this, let's go to the next question. A 3-year-old boy is brought to the emergency department after witnessed episode of swallowing a small shiny coin-like object while playing. He appears uncomfortable and repeatedly points to the lower neck and when asked where it hurts. He is having mild drooling, but otherwise he's stable. A chest X-ray shows a round radio opaque object with a double rim sign. So please make a note. They have given to you something very specific, which is a double rim sign, which is specific for a button battery. So when you see a button battery, you will think of many complications it can eventually cause. So it will release the alkaline material which is contained within the button battery to cause alkaline necrosis, and it can cause perforation, tissue destruction. All of that could be a possibility. Now, so let's see in the options, what is the potential fatal complication that could be anticipated in this patient is the question here. So when they're asking to you what is the fatal complication, we know that the button battery, which is understood by the double rim sign, will cause esophageal perforation with necrotizing mediastinitis. Tracheal compression with reactive stridor is less often a possibility because it's a small foreign body, not a large one. Mercury toxicity is not a possibility because they contain not mercury. And aspiration, pneumonitis from gastric reflux and vomiting can be a possibility, but amongst the two options, the better option is esophageal perforation. So, which is why that will be your right answer. Now let's go to the next question. What is the recommended procedure for removing an esophageal foreign body in a child? So similar question which we read before, if they give you that how would you remove the foreign body in that child? Of course, you will refer to a pediatric endoscopy and you're going to remove it. If you give glucagon and diazepam for muscle relaxation, it can go downward and slip into the stomach. You will not induce vomiting because that can further cause perforation and complications associated with it. Back blows and chest thrust is for foreign body in the airway, not in the digestive tract. Here they had clearly told to you that the foreign body is in the thoracic inlet, in the at the level of the upper esophagus. So with this we know that when there is a foreign body in the upper esophagus, you will refer to endoscopy for removal rather than doing anything else. Now we have a next question to you, where a 17-year-old male is brought to the emergency department after a high-speed motor vehicle collision. Neck inspection is showing to you multiple abrasions and lacerations in the cervical region. And as you evaluate him further, you notice that his voice is significantly hoarse and he struggles with swallowing. So which nerve injury is possibly happening in this patient is your question. So the nerve components for this presentation. So when a patient has a neck injury, there is a possibility of injury to nerves, commonly the superior laryngeal nerve, recurrent laryngeal nerve, glossopharyngeal nerve, vagus nerve. All these nerves along with other small nerves can be at risk. Now, since the patient is having difficulty in swallowing and the patient is also having hoarseness of voice, what is it we are going to think of? We know that larynx is going to be responsible for hoarse voice, and larynx is supplied by the recurrent laryngeal nerve. And because the pharynx is supplied by pharyngeal plexus, there will be a difficulty in swallowing. So the two important symptoms, hoarse voice, difficulty in swallowing, points towards combined pharyngeal plexus and recurrent laryngeal nerve injury. Okay, so I think that was quite easy. Let's go to the next question. A 8-year-old child with Down syndrome presents to you with painful neck movements that begin 3 days after undergoing tonsillectomy and adenoidectomy. So the patient is having, painful neck movements that began after tonsillectomy and adenoidectomy, and the patient is having limited intake of oral fluids. He is afebrile, meaning there is no fever, and the patient is normal but is uncooperative to identify if the Kernig's or Brudzinski sign is positive or not. So typically in children who have Down syndrome, we know that they have an atlantoaxial instability. And now in Down syndrome patient, if we do a tonsillectomy and an adenoidectomy, and if we put the patient in Rose position, what is the next possibility? There can be a non-traumatic atlantoaxial subluxation, and that non-traumatic atlantoaxial subluxation is responsible for causing something called as Griesel's syndrome. So in Griesel's syndrome, there is inflammation of the ligaments attached to the vertebral column, and along with that, there is subluxation of the atlantoaxial joint, making neck movements difficult, swallowing difficult. And since it is non-traumatic and non-infectious, the child is usually afebrile, and the patient will usually be uncooperative with neck movements because there is definitely going to be pain associated and torticollis associated. So the correct answer here is atlantoaxial subluxation. Eagle syndrome is nothing but elongated styloid process. It has nothing to do with tonsillectomy and adenoidectomy. Velopharyngeal insufficiency we've already discussed would present to you with nasal regurgitation, and meningitis patient would not be afebrile, the patient would be febrile. So with this, let's go to the next question. We have a question here where we have a 25-year-old man who's presenting to you with worsening nasal congestion, and he has purchased over-the-counter intranasal decongestant. The physician examines the nasal mucosa, which is edematous and erythematous. He's advised to discontinue the intranasal decongestants. Which of the following best explains the pathophysiology of this patient's condition? So if somebody is using intranasal decongestants, oxymetazoline, xylometazoline, these are alpha adrenergic agonist drugs. These alpha adrenergic agonist drugs, if used for prolonged duration of time, it can result in something called as tachyphylaxis, where the patient will have rebound congestion on stopping the drug and again reusing the drug. So the patient is having tachyphylaxis, and that is responsible for causing rebound nasal congestion in these patients. So initially there will be a period of relief of symptoms, and then even on usage, there will be a temporary relief followed by a blockage, which is more than before. So that should be your answer. Local mechanical irritation because of improper use of spray is wrong. Inflammatory reaction is not the cause. Chronic infection is not the cause. It is because of down regulation of the alpha adrenergic receptors. These receptors are getting accustomed to the drug, used to the drug, and that phenomenon where there is a chronic acclimatization of the drug, we call it as tachyphylaxis, and this should be your right answer. Now let's go to the next question. A 71-year-old woman with a 40-pack history of smoking presents to you with hoarseness and weight loss for the past 2 months. So whenever we have a patient who's presenting to you with history of smoking is present, along with that we know that the patient is having hoarseness of voice and the patient is having weight loss, the first thing that comes to you is a cancer. 70-year-old chronically smoking, chronically having hoarseness and weight loss, something that you think of as a cancer. Examination is showing to you that there is a 2 centimeter exophytic mass from the infrahyoid supraglottis extending anteriorly above the true glottis, and which has impaired but still preserves a small degree of mobility. There are multiple firm, immobile 1.5 to 2 centimeters lymph node corresponding to level 2, level 3 are also palpated. Contrast CT is showing to you that the extension of the tumor is anteriorly to the pre-epiglottic space and inferiorly 7 mm below the true vocal cord. Biopsy is showing to you a squamous cell carcinoma, and there is no distant metastasis. Concurrent chemoradiation has been given for laryngeal preservation. What lymphatic levels should be covered under radiation fields is being asked. So now we know that there is a patient who is having cancer of the epiglottis, and this is spreading to the glottis. And now the patient is having mobility of the vocal cord is still present, and the patient has extension to the pre-epiglottic space. So whenever there is an extension to the pre-epiglottic space, we ideally would categorize it into T3. Now, what is the end status? 1.5 to 2 centimeter lymph nodes at various levels. So it is multiple lymph nodes that are palpated. At what level? Level 2, level 3. But since there is involvement of the pre-epiglottic space, would you also think that the anterior compartment of the neck shall also be involved? Yes. So when you're thinking of chemo radiation and you want to irradiate the lymph nodes, of course, level 2, 3, and 4 is what you're going to radiate, because 4 is also close by in the same level. You have upper jugular, middle jugular, and lower jugular. So you're going to radiate all the three nodes, level 2, level 3, level 4. But level 6 also you will give the radiation because the anterior compartment with involvement of pre-epiglottic space is present. So you are going to radiate level 2 to 4 and anterior compartment, which is level 6. So this should be your right answer. Okay, so now let's do the end staging properly. So we have a 65-year-old man with hoarseness and pain with swallowing and earache. There is a 3.5 centimeter node on the left side of the neck. So 3.5 centimeter node on which side of the neck? Left side of the neck. Endoscopy showing to you a squamous cell carcinoma on the right-sided laryngeal surface of the epiglottis. So where is the cancer? On the right side of the laryngeal surface of epiglottis. Right? So whenever we do the end staging, we know N1 is the size of lymph node is less than 3. What is N2? It is between 3 to 6. And what is N3? It is more than 6. Right? So we know now this patient is coming under N2. But is it N2A, N2B, or N2C? This is our question. So we've learned that A will be first alphabet, right? A is first alphabet. So we've learned single ipsilateral node, which is 3 to 6 centimeters in size. Now we know this is not an ipsilateral node, but it is a contralateral node because the cancer is on the right side, node is on the left side. Right? So this is sorted. It is not an ipsilateral. What is B? It is multiple nodes, but ipsilateral node. But here we know that it is a contralateral node. C is it could be single or multiple, but they are contralateral. So now because the node is a contralateral node, we are going to answer this as N2C. So I hope all of you got the N classification in this patient. So let's go to the next question where we have a 67-year-old woman with a history of laryngeal cancer showing to you with respiratory distress 1 hour after tracheostomy tube change. Her respiratory rate is 28 breaths per minute and pulse oximetry showing to you a saturation of 88%. On further inspection, the tracheostomy tie appears loose. What is the best next step in the management of this patient? Now, since this patient is having tracheostomy after laryngeal cancer, what do we want to believe? This patient is probably having undergone a total laryngectomy. And now, because the patient has undergone a total laryngectomy, the patient is on a permanent tracheostomy. Now, if the patient is on a permanent tracheostomy and if you want to do a tube change and if you've changed the tube, after the tube change, if the saturation is falling to 88%, what does that mean? That tube has probably not gone in the trachea. It could be somewhere in the skin and the subcutaneous tissue area. So since the tube is not in the trachea, it could be in the subcutaneous plane, and as a result, the patient is having fall in saturation. What should you do? Now let's assume you replace the tracheostomy tube with a disposable plastic tracheal cannula. Yes, this is going to work because you remove the tube and reinsert a new cannula. That should work. This should be your answer. Ventilate with 100% oxygen. See, now there is no larynx. How will, and the patient is having a permanent tracheostomy. So from above, even if you give 100% oxygenation, how will it work? It won't work. Inflate the cuff with maximal pressure. If the tube is not in trachea, it is in the subcutaneous plane. Will it work? No. Remove the inner cannula and suction. Remove the inner cannula and suction will work only if there is a block with a mucus plug or a blood clot. Here, the tube is not in the trachea itself, so it won't work. So the correct answer is you have to remove the entire tube out, check what is happening, and reinsert a tracheal cannula. Or if you can't do anything, at least remove the tube and give oxygenation from the stoma. That's the least thing that you can do. Okay, so I hope this is clear for all of you. Let's go to the next question. So we have a 5-year-old boy who's referred for difficulty in hearing and mild right-sided earache. He has no acute infections. On otological examination, the right-sided eardrum is immobile with fluid behind it. When the clinician performs myringotomy, there is a continuous fluid that is pouring out from the tympanic membrane. So what is the next course of action in this patient? So now if we think about this patient, there is a fluid in the middle ear and that fluid is causing immobility of the tympanic membrane. The first thought that we have is serous otitis media or otitis media with effusion in this patient. So when we think of this, what will we do? We will do a myringotomy plus Grome. But after doing a myringotomy, if it is just an effusion, if you suck out, the fluid should come out and that is it. You should not see continuous clear fluid. But if you're seeing a continuous clear fluid that is coming, then it is not otitis media with effusion. It is a CSF otorrhea, which could be due to any cause, a congenital cause, a spontaneous cause, for any other cause it could be. So if we are thinking of CSF otorrhea, will you start first with antibiotic? Will you pack the ear canal with gel foam? Will you put a lumbar drain or you'll obtain a consultation from neurosurgeon? The first step, the next course will be to obtain a consultation with the neurosurgeon, identify why there is a CSF otorrhea, then maybe you can give IV ceftriaxone to prevent any meningitis and lumbar drain to reduce the fluid that is pouring into the canal. So first you will obtain an immediate consultation with the neurosurgeon. So I think that is sorted. Let's go to the next question. A 60-year-old man with a left-sided facial weakness is diagnosed with Bell's palsy and rest of the things are okay. They're asking to you which of the following is this patient expected to have difficulty in performing. So in Bell's palsy, will you have difficulty in opening the eye or closing the eye? Of course, closing the eye. So this is wrong. Will you have difficulty in moving the tongue? Of course not, because tongue movements are by the hypoglossal nerve, not via the facial nerve. Biting down on a tongue depressor is a feature of the masticatory muscles, the masseter, temporalis, medial and lateral pterygoids, which are supplied by the trigeminal nerve. So this is not the answer. But yes, raising the eyebrows, smiling, blowing of the cheeks, all of these are functions of the facial nerve. So raising of the eyebrow will be a difficulty in performing the task. So this is very simple. So we go to the next question. A 75-year-old man with chills and severe ear pain for 7 days presents to you with a poorly controlled type 2 diabetes. So diabetes telling to you a erythematous red auricle with granulation tissue at the bony cartilaginous junction. We know the diagnosis is very simple. It is nothing but malignant otitis externa. Age, diabetes, uncontrolled, granulation tissue, all of these are features of malignant otitis externa. For malignant otitis externa, the drug of choice is piperacillin tazobactam. You can also combine with aminoglycosides. Voriconazole is given if you suspect a fungal infection. Again, nystatin is for fungal infection. Tobramycin topically may be applied, but the first line of treatment is going to be anti-pseudomonal antibiotics like piperacillin or meropenem, imipenem, aminoglycosides. So dual combination therapy is given to these patients with malignant otitis externa. Now let's go to the last question. A 9-year-old boy presents to his younger sister. A 9-year-old boy presents after his younger sister bumps to him while he's cleaning the ear with an applicator. The patient had sudden onset of pain and that has resolved. On physical examination, there's a small tear in the antero-inferior part of the tympanic membrane. What is the next step in the management? We know this is what? It is nothing but a traumatic perforation. So when we have a traumatic perforation of the tympanic membrane, what is it that we are going to do in terms of treatment? Next step will be to discharge the patient to home, and since it is going to heal spontaneously, you'll ask the patient to keep the ear dry and follow up with the primary care. See, urgent otolaryngological referral is not necessary because, see, there is a traumatic perforation, it will heal. And if it does not heal, then you send to an ENT specialist. That is acceptable, which is given into your last option. But this is not something that you would do with antibiotics, send for ENT consultation. Yes, you can do, but that's not the most appropriate. The most appropriate is you have to instruct the patient to keep the ear dry, no ear drops, because they will go to over the counter pharmacies, ask that I had a hole in my ear, give me some medications, and they will take drops and they will put drops, which is not the ideal situation. So no ear drops, no water, the ear has to be dry. That is the primary modality of treatment. Refer to the urgent primary care, that can be done, but antibiotics usually not necessary. Obtain emergent otolaryngological consultation, again not necessary because they heal spontaneously. And admit for consultation and antibiotics, no, you just have to keep the patient home, give and keep the ear dry and send again for review to a ENT specialist. And if there is a residual perforation, then you will do a myringoplasty or a tympanoplasty. So with this, your 15 questions of the tricky series is done. I hope all of you enjoyed this series, and we will have again on Saturday. You will have next set of questions where we will do 15 questions, and I will come back again with the video solutions for all of you on my YouTube channel. Take care, guys. Thank you, and bye bye.